Thank you, sir. Thank you for giving me this opportunity. So as we all know, ROP is vasoproliferative disorder of retina seen in preterm infants, and with advancing neonatal care and increase in survival of preterm births, ROP is becoming the leading cause of preventable childhood blindness throughout the world. We did a small study aiming to find the incidence and risk factors predisposing to ROP and to assess the outcomes after laser photocoagulation for high risk pre-threshold or type 1 ROP in NICU of multiple referral hospitals. It's a retrospective study. We studied 1,648 eyes between April 2015 to March 2016. It's a 12-month study, and we followed strict ICROP guidelines. All infants were screened by the same ophthalmologist, and infants with birth weight more than 17,700 grams and gestation more than 35 weeks were screened on neonatologist discretion only. Screening was done in 17 referral hospitals in Cochin. We followed strict newer Indian guidelines of screening birth weight less than 1,700 grams and gestation age less than 34-35 weeks. All infants which were born less than 28 weeks or having weight less than 1,200 grams, they were screened early at 2 to 3 weeks as compared to the normal screening protocol. All screened were with intact ophthalmoscope and 20 diopter lens. And screening and treatment was done according to the ATROP classification of type 1 and type 2. All cases with type 1 were done laser treatment alone, and all 2 were just observed. So laser treatment was done in both eyes irrespectively in preterm baby showing type 1 ROP. Infants with ROP were examined periodically or weekly till they completely regressed or till they reach high risk pre-threshold and threshold ROP, which mandates laser treatment. Follow was terminated once retinal vascularization completed till periphery in all quadrants. Total 1,648 eyes were screened with mean gestation age of 31.76 weeks and mean birth weight of 1,468 grams. Incidence of total ROP was 25%. Incidence of type 1 ROP was 9.95% and AP-ROP incidence in our study was 20.73%. There was significantly decrease in gestation age and birth weight with increase in ROP incidence in our study. And there was no ROP was found in infants with birth weight more than 2,000 gram and gestation age more than 36 gram. And there was no type 1 ROP seen in infants more than 32 weeks of gestation age. Eyes with type 1 ROP was received laser treatment alone. In babies with type 2 ROP, we see stage 1 in 32%, stage 2 in 60%, and stage 3 in 7.08% of babies. We studied various other risk factors also like hemoglobin, oxygen requirement, hours on ventilation, number of blood transfusion, and septicemia, and we saw statistically significant correlation between type 1 and type 2. And if you see, we saw hemoglobin 9 as a cutoff for worsening in type 1 ROP and hemoglobin of 12 for worsening in type 2 ROP. We did multivariate analysis and seen that hemoglobin reduced more number of blood transfusion and more requirement of oxygen, more oxygen requirement is more statistically significant with type 1 worsening as compared to type 2 worsening. More than one laser treatment was performed in 12 eyes. Even after appropriate laser treatment, 3 eyes worsened to form falciform fold over the macula, and 1 eye developed retinal detachment. All 4 were unfortunately lost to vision. None of the studies neonates initially presented with stage 4 or 5 in our study. 5 infants were born at gestation age between 24 to 25 weeks and were given laser treatment at early age of 29 weeks, post-gestation age. We saw 6 babies with birth weight of more than 1,700 grams who had ROP, and for this we treated 2 babies which has stage 3 plus disease, and all of these babies are having septicemia, RDS, one has RH incompatibility also. So to discuss, premature infant is not born with ROP and has normal visual potential at birth. Vinegar et al. Has suggested larger and with gestationally older infants in India can also develop ROP as compared to their counterparts in Western countries. Lower gestation age and lower birth weight are statistically significant factors for worsening of ROP. Considering logistics in developing country like India, Jalali et al. Explained importance and technical aspects of laser as a preferred treatment modality. We would have missed 25% of eyes if we had screened according to American Academy guidelines, and we would have missed 3.82% of babies if we had screened according to old Indian guidelines. If we had screened according to ICROP guidelines, we would have still missed 10 eyes, which we have given laser at an early age of 29 weeks. Our study's results were comparative to other studies seeing the risk factors and other factors. So to discuss, contrary to recurrence rate of 26% after laser treatment in beta ROP, we found recurrence of only 0.72%, that is 12-wise in our study after laser treatment. Moreover, beta ROP study showed promising results for zone 1 and not in zone 2. Wei Chu Wu has documented significant systemic risk factors like vascular sheathing and developmental delay in babies who has received anti-VEGF, along with ocular risk factors. Though ETROP study has shown poor anatomical and functional outcome in zone 1 and zone 2 after laser treatment, still laser treatment holds as a gold standard treatment with excellent results of only 0.2% unfavorable outcome in our study. Anemia, increased oxygen requirement, and other risk factors are significant risk factors of worsening ROP in our study. To conclude, incidence of ROP has was 25% with out of which only 9.95% need laser. Considering 5 infants treated with gestation age at 29 weeks, we suggest to screen and babies less than 29 to start screening babies less than 29 weeks, and despite not using anti-VEGF, we get very good excellent results, more than 99.8%. Even in larger and gestationally old babies associated with systemic risk factors, we can see ROP. So even larger babies should be screened, but on neonatologist discretion. This is our study.
I think